Hello. Can you see me? Can you listen then?
Can you hear me, Amin?
Hello, can you hear me?
I can hear you, mate. I can hear you loud and clear.
All right. Can you?
I don't know whether I can see you or whether you're just very still and you're not social distancing.
Let's. I stopped the video. Can you see me now?
I can see the top of your head. There we go. I can see you, mate.
Can you see? Is it sharing the screen?
Yeah, I can see your screen, mate. Beautiful. Little picture, little cartoon. Yeah.
And it's changing.
Yeah.
Yeah. All right.
Have you got any videos or anything that you're running?
I tried to run a video, but it's not working properly. I'm not sure what to do.
What were you wanting to show on ETV or something?
Yeah.
So can you not just like on your screen now, just go on, is the one on YouTube, which is good, or you should be able to just go on YouTube now and just like search ETV and then play it and see whether, just put it on full screen or something and see whether it plays on mine.
Let's see. Is it playing well?
Can't see it. So all I can see at the minute is your PPT.
That's what happening. Like when I'm trying to. Okay, let's see. Can we? I think there's a way we can change the screen we're sharing. Yeah. Can you see it now?
Yeah.
Yeah. All right. That's fine.
So give that a play then. Perfect.
Yeah, it should be all right. Okay.
Yeah, it's a little bit jumpy, but I think to be honest, like the webinars that I've been looking at it's all been jumpy because you're relying on two people's internet, aren't you?
Yeah.
You know, so I wouldn't worry about it too much.
Okay.
Give the Menti a go. See what happens with it, mate. It can just complicate things, I reckon.
Yeah.
So
I'll just give the link and see whether it works. If it doesn't, then it doesn't.
You can try. Or see what you think anyway. But like, I think it worked well for what's his name, Simon Coldip's. But I think for Rob Simmons it didn't work as well.
Yeah.
So I don't know. I mean, the problem is if you ask questions, then in general you don't really get answers. That's what I've found anyway. Doing stuff. But yeah, see what you think, mate.
All right. So it's still have 7 minutes. I'll get back to you in 7 minutes. I'll just try and see if I can do something.
Just take your time with it, mate.
Yeah. All right.
Yeah, I'm sure it'll be good. Amount of CSF in the ventricle. Bloody hell, mate. I don't know any of this. 25 mils.
Yeah.
Yeah. Do you know why I know that? Because if you take 30 mils off an EVD, you get compliance back. So whenever anyone's you got like an EVD clamped and you need to, and someone's unconscious, always take 30 mils.
All right.
30 mils is the number. All right, mate. Cool. Oh, looks good.
Okay. Okay. Let's see.
All right. Well, I'll hang around there. Is it what time? You starting at 1:30, so you've got 6 minutes, isn't it? So
Yeah, I've got 6 minutes. So let's see.
okay, well, I'm going to go and have a
All
piss,
right.
and then I'll.
Yeah. See you soon. Can you hear me?
I am in, yeah, I can hear you, mate. Just let me go and move it to another room. Is it just me so far?
You and Dan.
No, mate, I'm here.
Right, just give us a second. I'm just going. Just trying to find a spare space.
You might want to stop sharing your screen. I'm in, and then just share it once everyone's in. So what have you been doing, mate? Have you been doing any operating?
I did the one redo chronic subdural when I was on call.
Yeah. This is the one that caused the anaesthetist problem.
Yeah. And I think he ended up going to theater again the next day because for a mini craniotomy because he kept collecting. So it was a nightmare.
Mate, never underestimate those naughty chronic subdurals, mate.
Yeah.
Never underestimate them. Chronic subdurals and teaching people how to breathe. Oh my God, look at that.
Is it working?
What room are you in there, Matt?
34 Q4 anaesthetic room.
Oh, right. Oh, yeah, okay, yeah. Yeah, I was sitting in there yesterday.
Yeah, is it all right?
Yeah.
Good. Case go okay?
Yeah, it went well, mate. It was a difficult case. It was a vascular one, so just bled a lot.
Yeah, we've just seen him. He's doing bob on. Just sending him down to the normal ward today.
Sound. Facial nerve, all right, yeah? Yeah, we couldn't get all of it out, mate, so I wasn't expecting the facial nerve problem. I had to leave a chunk in, but...
You never know with these cases, do you?
Yeah. What have you got on today?
Well, I'm on emergencies. So we initially were going to try and get... There's a lad who came in under Macrobacter's tank, acute subdural, conservatively managed young lad. We thought he was going to die. He blew his pupils or something. In the end, he didn't die. Ramez ended up decompressing him back 3 days later. Massive infection, all on the dominant hemisphere. Bit of a shit story. Anyway, he's in rehab and not doing too well. Vents are up. So there was a bit of a, shall we or shan't we? We brought him over to try and get a shunt into him. But at the moment, you've got 2 cases on Q floor, and E floor has got 7 cases. We're just not going to be able to put a foot down and get any space.
Well,
so
mate,
we're putting a lumbar drain and see if we can, if he improves.
If you end up banging a shunt in, this is going to be a nice little revision session from Andy. I know not to cross to the other side.
Matt, has he actually come over?
Yeah, he came over late yesterday by the sounds of things.
Yeah.
Just trying to get him into theatre is proving to be a bit of a nightmare.
Yeah.
So Mr. Bacon, as you said, stick in a lumbar
Lumbar
drain.
drain. Yeah.
If it doesn't improve him, the shunt's not going to help, sort of thing.
Yeah. Yeah. I mean, the reason why he was going to come over early, but he was pyrexial, and the last COVID swab on him was 3 weeks ago. So Patricia wanted a swab first. Then she was told he was still pyrexial, even though that was negative. And then there was no space. I think yesterday. Did he come yesterday evening then?
Yeah, I believe so. Yeah.
Yeah.
Yeah, and there's been effectively no space today either. There's a topic, then there's a trachea on a COVID patient, then there's cases of and big max fax abscess. The problem with theatre across the Hallamshire, there's just no space.
It's been busy all week. It's been surprisingly busy all week, and that Max Fax case is an IVDU, keeps absconding and eating McDonald's and things, and then coming back. You know, can't go to theatre, but he's been kicking around all week.
McDonald's from?
Yeah, that's right.
Well, he's IVDU.
Can you invite him
anything,
to get him to share his secret?
Yeah, these guys get heroin on a daily basis, but actually, the most difficult part of their day is getting a McDonald's. Hey, the Smacks, no problem. It's the fucking Mackies. Yeah, so just all turning into a bit of a logistical nightmare. I mean, I said it again, I think we're going to have to turn our hand to operating more overnight.
Yeah, but then you hit the obstruction of the anaesthetist, don't you?
Yeah.
And I think they were insisting consultants come in. Like was it with you, where they insisted a consultant comes in for a burr hole washout?
Yeah, if it was
Stuff
done
like
under GA, then they demanded Mr. Al-Tamimi to come and do
What consultant know how to do a burr hole washout of a chronic subdural?
Say
I
again?
don't know any consultants that would be able to do a burr hole washout of a chronic subdural.
I think it's difficult time, needs difficult.
Mr. Actual had to come in to do an EVD in Hull last week, and it took him an hour and a half.
Is that because Stuart was asleep again? Sorry, Stuart, if you're here.
Actually, Jerry scrubbed for chronic subdural with me when it was Mr. Atchwell's father-in-law.
Oh my God.
And he just slowed things down. It was horrendous. And then he desterilised the surgical field. He de-scrubbed and then put his hands on the head. It's just bizarre.
I think you've got the floor, mate. You've got quite a crowd.
Yeah, shall we start?
Looking good, yeah. Just before you start, mate, are you recording this?
Do you want me to record this?
Well, yeah, we're trying to work out because, obviously people can't get to this all the time. I've just been chatting to Hume. We're trying to work out how to do it.
Yeah, it
And
does
on
on
my
mine.
screen,
Yeah,
it says
I am recording it.
I haven't
Recording it.
You are recording, okay.
Yeah.
So can you work out, mate, at the end of it, how to like share your recording?
Yeah, can do.
But obviously, delete that first bit where we're slagging off all the consultants.
All right. No worries.
And just try and work it out, mate.
All right.
Yeah,
So
go for it, Amin.
let's start. Give me a sec.
So everyone mute the microphones, yeah?
Can everyone see it?
Yeah.
All right. So welcome everyone. And I'm really sorry if this video stops working because of the technical problems. But if everything goes all right, then we will try and understand the ventricular anatomy today. Hope everyone is healthy and safe. So before we start the lesson, I want all of you to, so this is what we will cover today. So the basic concept of ventricular anatomy, important relation, vascular supply, some surgical consideration, possibly some pathology, but I would like you to remind that this is an anatomy teaching. So if you bugger off in the middle of the lesson, I wouldn't mind.
What's atomy?
It's anatomy.
Sorry, mate. Sorry.
So for the next half an hour, I would like you, so all of you, to picture yourself in a 3-storied detached house with 2 bedrooms at the top floor, and then a kitchen on the first floor that is having separate access from the both bedrooms at the top, and then the kitchen leading through a very narrow staircase to the ground floor where you have maybe an patio or like a living space, and which then communicates with outside through 3 separate doors. So this is I think the quality of the picture is very poor, but this 3D model is made by University of Washington, and it gives you a very rough idea of the entire ventricular system. So as you can see, you have the ventricular system located in the depth of the brain, and grossly you have 2 lateral ventricles which are kind of mirror image to one another sitting on each hemisphere. And then in the midline here, can everyone see the mouse pointer?
Yeah.
So in the midline, you have the 3rd ventricle, and then the 3rd is leading through the aqueduct towards the 4th ventricle. So the only thing I want you to carry from this 3D model is the shape of the lateral ventricle, because I would like to say today's lecture of anatomy will be with the letter C or alphabet C. So you can see the lateral ventricle, it's roughly a C shaped. And in today's lecture, we will see a lot of C. So moving on, this is a very rough drawing of the ventricular system and the CSF flow through it. So you can see that that's the lateral ventricle, and it's communicating with the 3rd ventricle here through the foramen of Monroe. And you can see choroid plexus secreting CSF, and then from the 3rd ventricle through the aqueduct, it's going towards the 4th. So this is your, if you remember your 3-story detached house, and this is your patio downstairs, you will have 3 openings. So one midline aperture and two lateral aperture. The CSF goes outside and it circulates in the subarachnoid space. So as I said, it's a very rough diagram showing the CSF flow inside the central nervous system. So earlier I sent this quiz. Did anyone manage to answer that on Menti? Anyone?
Do we not do it? Do we not do it as we go, Amin?
Say again?
Do we not just do it as we go? So I'm on it now, and I can see your question.
Yeah.
Amount of CSF in the ventricle. So I think if everyone just logs onto it now, and then I think you just click through it, mate.
My first question is surface marking of foramen of Monroe.
There's a different one. Try the first one. Sorry about messing
there's a
it up.
second link you can.
I've only got the foramen of Monroe question on both of the links.
Sorry about that. So just everyone tell here, what do you think is the right amount of CSF in the ventricle? Like the whole ventricular system, how much CSF does it contain? Duncan?
125.
All right. Anna?
50.
All right. Who else? Matt?
Hey, 125, I think.
All right.
I'm
David?
going to go 25. Amin.
All right. David?
50.
Okay, so the correct answer is 25 mils.
Thank God for Google.
I think 25 mils I'm in.
25 mils. So 25 mils is the right answer, even though it sounds really surprising. So 125 mils is the total amount of CSF inside the CNS, and only 25 mils stays in the ventricular system. The rest of it is in the subarachnoid space. So it's really small. And moving on. So now is the boring part coming in. So I want you guys to try and keep focused. So these are the important relationships, neural relationships we would like to know when we are navigating through the ventricle. So the first is thalamus. It's like the center core of the ventricular system. And then we have the caudate nucleus. We have fornix, corpus callosum, septum pellucidum, and internal capsule. So next picture is again is a 3D model. And if you remember the alphabet C, so you can see that the lateral ventricles here, that's the lateral ventricle. It's a C-shaped structure, which is like kind of encapsulating the thalamus. And it's also kind of very roughly a C-shaped. And at the bottom of the C, you have hypothalamus.
I mean, have you got like a waiting room for this? I think Shamoitri's trying to join as well.
Let me see. No, there's no waiting room.
Okay, don't worry. I'll give it a shout. I'll see if I can get it in.
All right.
Don't worry, mate. Just carry on. I'll give it a call and I'll
Okay.
see what's wrong.
So you have this lateral ventricle, then you can see the thalamus. So you can see, you can quite appreciate how thalamus is in the kind of center of the ventricular system, along with hypothalamus. There's a couple of other C-shaped structures which we will encounter later on. But one thing is the corpus callosum, and then you have fornix in between the thalamus and the ventricular surface. So moving on, so you can see the corpus callosum here, the yellow bit. And so this is a sagittal cut through the midline of an actual human brain, and it's showing the corpus callosum. This thin black line is marking the fornix, and then you have the red dot, which is the thalamus. And this is indicating the foramen of Monro. And you can see the lateral ventricle over there, and this thin curtain that is hanging from the corpus callosum is the fornix. It's the septum pellucidum, sorry. And so this is the thalamus. Here is the third ventricle, and you can see the aqueduct of Sylvius leading towards the fourth. So try to remember the position of the corpus callosum from this picture, because as you can appreciate that the corpus callosum, it's the C in front, it's kind of like covering the whole ventricular system. So it's making part of the frontal anterior wall and part of the floor down there. So this is the axial cut, and here you can see again the lateral ventricles, the frontal horn, and then you have the atrium leading towards the occipital horn, and if you go down there, that will lead you to the temporal horn. And in the midline, this slit-like structure, it's the third ventricle. So here, again, we will see the important neural structures related to it. So first, you have the corpus callosum. So if you remember the previous picture, you can see how the corpus callosum starting from the front, going all the way to the back. And then you have the caudate nucleus sitting on either side of the frontal horn. And these two big structures, which I personally feel is the most important relation to the ventricular anatomy, is the thalamus. And then we have the internal capsule. So that's the anterior limb of the internal capsule, and the posterior limb, and where the two limbs meet is the genu of the corpus callosum. So one thing I want to take like a take message from this picture is, if you can see, this is the lateral horn or the frontal horn, and this is the third ventricle. So this is the location of foramen of Monro. And you can see how closely the internal capsule is related to the foramen of Monro. And also you have the thalamus here, and in the midline, you have the fornix. So I feel that foramen of Monro is very scary location, because if you damage any of those structures, you don't want to do that. Moving on. So now we'll start with the lateral ventricles. So roughly we can divide it as the frontal horn, then body, then we have the atrium and occipital horn, and the temporal horn. So grossly speaking, I think if you have this cerebral hemisphere with, for each lobe, kind of, you have one projection of the lateral ventricle, and hence it's the ventricular system of the cerebral hemisphere itself. And again, you can see the relation of the thalamus and hypothalamus. So first we'll start with the frontal horn, and this is a coronal section and sagittal section. So what I want you guys to appreciate is that if you see this coronal section, you can see that possibly this is from a very young adult, and the ventricles are small. But if you look at this one, possibly someone with a degenerative disease, or maybe an elderly person, where the brain surface and the cortex and the white matters are quite atrophied, which makes the ventricle looks bigger. And on the sagittal section, you can again see the corpus callosum, lateral ventricle, and the structures you have here. So you can see the corpus callosum is forming the anterior wall of the frontal horn, and also roof of the frontal horn, and part of the floor of the frontal horn. So this part, the anterior wall and the roof, is formed by the genu of the corpus callosum, and you got your floor by the rostrum of the corpus callosum. And here on the cornal section, you can see the caudate nucleus, which are forming the lateral wall. And in the midline, you have the septum pellucidum. So if you again imagine yourself in the room of that 3-storied building, one of the part of the bedroom is formed by this frontal horn, and you have your walls. And moving on to the body. So body is a bit more complex than the frontal horn itself, because here we have more structures. So if you remember this part, so frontal horn extends from the foramen of Monro. So the part of the lateral horn that is in front of the foramen of Monro is frontal horn. And here you can see the foramen of Monro roughly here. And body extends from the posterior edge of foramen of Monro to a part where you can see the septum pellucidum. It's kind of disappearing. And this is your fornix. It's meeting with the corpus callosum. So this part is the body. And so as you can see, the roof, again, here on the coronal and on the sagittal, you can see the roof of the body is formed by the corpus callosum. And medial wall, if you see in this picture, so at the top, it's the septum pellucidum, as you can see on the sagittal section as well. At the bottom of the medial wall, you have the body of the fornix. And so you have the roof, you have the medial wall. If you go to the lateral wall, those are the caudate nucleus. And the floor is formed by the thalamus here. So roughly it's again, corpus callosum is forming the roof, and you have the thalamus. So we'll see how thalamus on and off comes in very close relation to the ventricular anatomy. And now from body, we will move to atrium and occipital horn. So before we move on and go into the anatomy, I would like you to appreciate this picture, because what I found is that this is a very important surgical landmark and surgical importance when you are operating on the either temporal horn or occipital horn. So who can tell what's A? Anyone?
Optic nerve.
Optic nerve, that's great. And moving on to B, what's B?
I think it's a pituitary stalk, I believe.
Yeah. And then C, what's C? Anyone?
Optic tract.
All right. What about G?
Memory bodies.
Mammillary bodies.
All right. And what about D?
It's optic radiation, I believe. Or...
All right. So I am not sure whether you can access it on Menti. I gave a question about the second picture about E. So can you see it on Menti? Is it coming up?
No, it's not on mine, mate.
Is it on your, can you see it? Name the structure
No,
E.
sorry.
No.
No.
Sorry. So the Menti is not working. So who can tell me what's the name of the structure E?
Is it Mayer's loop?
Yeah, it's Mayer's loop. And then you have the optic radiation. So, and what about H? Who can tell what's H?
It's third nerve.
Yeah, it's third nerve.
Yeah.
So, as you can see that, so this is your hair on the right side, you can see this is your atrium. Below, you can see the temporal horn behind you. So it's like a complex, triangular complex. So you have temporal horn coming up, occipital horn coming from the back, and in the middle you have the atrium or trigone. And this Mears loop, it forms, it's on the roof of the atrium and occipital horn. And it's very important because I got I get to know that when you're trying to operate here, and if you come transcortical, there is a very good chance that you will injure the optic radiation. And also, if you are trying to operate a trigonal tumor, and if you put too much lateral retraction on the roof or the lateral wall, then you can possibly damage this optic radiation and give disability to the patient. So it's a very interesting thing that I come across. Moving on, this is again a coronal section, and I didn't get any live good pictures of the temporal horn apart from this one. So I hope you guys can appreciate this. So this is pointing towards the temporal horn, and the floor of the temporal horn, you can see this structure here is the very beautiful structures, the hippocampus. So the floor is formed by the hippocampus, and it's not very clear on this side, but sometimes you will get a prominence laterally, which is the collateral eminence. So this is possibly your collateral sulcus, and which goes inside the ventricle, make a small prominence called the collateral eminence. And if you can see the roof here at the top, so medially you have the thalamus here forming the medial wall of the medial part of the roof, and then you have this white band of structure, which is the tapetum. So again, this tapetum, it separates the roof from the optic radiation. So again, if someone is performing like a selective temporal lobectomy or a temporal lobectomy for epilepsy, you have to remember the close relationship of the optic radiation here at the roof of the lateral horn and the temporal horn, sorry.
Amin, can I just ask you a quick question, mate?
Yeah.
It's just flashed up on my screen that you've upgraded to unlimited minutes. How did you do that?
So you have to schedule the meeting beforehand. Yeah. So I didn't know that. So when I came to know that if you make like a schedule meeting, let's say for next week, then Zoom will give you unlimited.
Okay.
So
okay, sorry, mate. To interrupt.
No, it's all right. It's all right. And in this structure, this picture, you can also see that some of the. I'm not going into the nuances of the surgical approaches, but you can see one of the approaches can be trans-Sylvian, and also I have done a couple of temporal lobectomy with Mr. Ushokunj, and he used to do, like he likes to do, so he stays below the Sylvian fissure, comes here. So the thing I got like is very important, I think, is that relationship of the optic radiation here. So I hope you guys are still awake, because we are moving to the center of the earth, and that's the third ventricle. And I presume that most of us, or almost everyone, have done ETV or seen ETV, especially with Mr. Sinha, and you have seen or come across some of the structures. So this is the third ventricle, and you can appreciate that that's the lateral, ventricle and it sits below the lateral ventricle. So who can tell me what's the medial wall of third ventricle? What forms the medial wall of the third ventricle? Matt?
The thalamus.
All right. Osama?
Do you mean the lateral or the medial?
Medial wall.
I mean, it is a central structure.
Yeah. So if you remember the example I gave you earlier, it's the kitchen of that 3-storied building. So it's in the midline. So there isn't any medial wall. And it's a singular structure. So you can see the thalamus on both sides. So thalamus from the lateral wall. And sometimes in between two thalamus, you have this massa intermedia, which connects the two thalamus. In 75% specimen or in 75% cases, you can see the massa intermedia. And so there is a very good, it's not an example, like a imagery. So you can, if you can pay attention, you can see this is the head of a bird with open beak. It's mentioned in the roton, and then I saw it closely and I see it's right. So you have this bird's head with open beak. And so the head of the bird is formed by the thalamus. And the two beaks, the superior one is the optic recess, and the bottom beak is the infundibular recess. So you have the optic chiasm somewhere here. It's not seen in this picture. And you have your infundibulum here. And then you have your mammillary bodies at the bottom, at the back. And you have the anterior commissure here. And so if we go very quickly through the boundaries, so you can see the lateral foramen of Monro communicating the lateral ventricle with the third ventricle. And we say the lateral wall is formed by the thalamus. And you see the roof here. We'll come to the roof in a second. So yeah. So if you can see this picture, you can appreciate the anterior and posterior wall of the third ventricle. So you can see the anterior wall is extending from the foramen of Monro at the top and going down to the chiasm. And it has column of fornix and anterior commissure as the part. And if you look at the back, this is the posterior wall of the third ventricle, and the structures you can see if you go from down upwards. So you have the opening of aqueduct of Sylvius, and if you go up, you have the pineal, and there is something called suprapineal recess, which is a recess just above the pineal, and it forms the posterior wall of the third ventricle. And before things goes crazy, I want to let you guys know the most important thing about the third ventricle is the, so it's the floor, because when we are doing ETV, we are trying to make opening on the floor of the third ventricle. So if you go from forwards to backwards, you have the optic chiasm, you have the infundibular recess or infundibulum, then you have your mammillary bodies, then you have the midbrain tegmentum, and at the back you have your aqueduct. So those structures form the floor of the third. And so if you are doing an ETV, so your scope will come, if you follow the cursor, it will come here, you will try to find out the choroid plexus, trace it to the foramen of Monro, and then you will look straight down on the floor. So if I ask, where would you like to do your ETV? Is it on A, B, or C?
I'd like to do mine at C.
Yeah,
Yeah,
good choice.
that.
Good choice, mate. Anyone want to do it at B?
I'd do it at B.
All right, and who will do it at A?
I think A is a proton.
So I think if we look at this picture, the safest area would be in front of this bad boy. So you don't want to go.
Sorry, I was looking the wrong way round.
I know you can't take your answer back now, I know.
Can I take mine back?
Yeah, I think you can do it at C and try to make it a big aqueduct. But the safest way to do it is hopefully in front of the basilar, because you don't want to end up with a dead patient on the table. And so this is the cistern where you want to make the opening. And also you can really appreciate how closely related the vascular structures at the floor of the third. And it's really scary when you see this. So moving on, as I said, we have left the roof of the third. We'll come to discuss that in a moment. Before we do that, we'd like to just pass through this choroidal fissure. So as I said before, there's a lot of C in our today's lecture. So you can see the corpus callosum, the lateral ventricle, then you have your fornix, and you have your thalamus. So choroidal fissure is basically a natural cleft. It's a C-shaped cleft that's between the fornix. You can see the white bit is the fornix and the yellow one is the thalamus. So it's a cleft between your thalamus and fornix. So it's one of the natural corridor that will lead you from lateral ventricle above to your third ventricle. Also, it will lead you from the frontal horn. Sometimes you can go to your lateral horn, and even you can go to the basal cisterns using this corridor. So moving on, this picture. So it's again, I think it's one of the, because before I did this talk, I asked around that what you want to get out of this lecture. So one of the feedback I got is that how will you identify which ventricle you are in? So this is a view of the ventricles. You can see you have, this is the corpus callosum, one of the lateral ventricles, one of the lateral ventricles. You have your foramen of Monro. So who can tell which one is the right lateral ventricle, A or B? So starting from Ed. Is Ed there?
Yeah, sorry, I was just having trouble with Zoom. Is A the right?
A the right, all right. Matt Sanders, A or B, the right ventricle?
Go on, go B.
B, all right, 50-50 chance. There's nothing in between. Then Matt Crank.
I believe the B is the right-hand ventricle.
All right. Moving on, Alex.
B.
B. Who else would like to vote for A? Anyone? All right. So I tried to make a very simple diagram, but I couldn't. So forgive me for that. Yeah. Anyone? Someone's trying to say something.
Sorry.
All right. So once you are inside the ventricle, whether you are holding a scope or you are under the microscope, doesn't matter. The first thing or the most common thing you will try to identify is the choroid plexus, because sometimes the foramen of Monro can be blocked due to the pathology itself. So the thing you try to identify is the choroid plexus, this structure, and the hello. Anyone want to say something?
If those are, I think that might be your mic, mate. You just need to click it off.
Oh, sorry.
Hi, Fosa. So you can see this choroid plexus will form kind of communion with two other veins. So one will be your septal vein coming from the septum pellucidum, and one will be your thalamostriate vein coming from the thalamus. And these three will join at a peak, and it should be the foramen of Monro. So when you see the big vein on the right side of choroid plexus, you are in the right ventricle. And when you see the thalamostriate on the left of the choroid plexus, it's the left ventricle. So that's the easiest way to remember. So you can see.
Unlucky, Ed.
Yeah. So as you see, this is the frontal horn. So you have your caudate nucleus there, thalamus here, and then this is your foramen of Monro. This is column of fornix. Somewhere here is the internal capsule. So as I promised, I will describe the roof of the third, because that's what's left. So move on.
Just a note, just as an aide memoir, I remember the S's, so it's septal small. So obviously the septum's in the midline.
Yeah.
You see the small vessel, septal side, you know, that's the midline. And then the chunky, because sometimes the anatomy can be quite messed up.
Yeah.
And then one is the one that's going laterally, the thalamostriate.
Yeah, that's quite right. So I think this view, you will get this view once you are coming from the top through the corpus callosum, so transcallosal, and you will either end up on this side or this side. So those are the ways to remember which is which. And then, so the roof of the third ventricle. So if we go back a couple of pictures, so you can see that's the roof of the third ventricle. So that's your lateral ventricle, that's your fornix, and it's beneath the fornix. And this is a very, I don't know how to describe it. So it's a very rudimentary place which has lots of vessels, and it has a very fancy name. So I'll tell you what that name is in a second. So if you remove the fornix, so you can see this is the same picture, we just remove the fornix, and this view comes in. So you have the two internal cerebral veins. You can see the fornix, the corpus, the choroid plexus. So the important thing to remember here is, because as I said, if you go to this picture, the choroidal fissure, it has two surfaces. So one is thalamus, one is fornix. And if you want to operate safely, it's always on the fornicial side of the choroid fissure that you need to go. So this is your choroid plexus, thalamus, fornix. So you need to go on the fornicial side. And if you reflect the fornix, you'll find this, you will be in the roof of the third. So who can tell me what's the fancy name of this structure here?
Velum interpositum.
Oh, there you go. Mr. Brown have said rightly. So it's a velum interpositum. It's a very fancy name. So you have, So you can see that you have the internal cerebral veins here, you have tela choroidea, and if you do very beautiful dissection, you will find this medial posterior choroidal artery, and then if you remove that, you will end up on the third ventricle. So these are the small structures in the roof of the third that you need to remember if you are accessing the third from the lateral. And now we'll move on to the vascular supply or vascular relation of the ventricular system. So the most important artery is the anterior caudal artery, and it comes from the ICA. And you can see, so this is the your lateral ventricle. So the choroid plexus, it originates from the lateral, goes up, trace, and then comes towards the foramen of Monro. So two of the arteries, the anterior choroidal and lateral posterior choroidal, they enter through this point and forms the choroid plexus. But the medial posterior choroidal artery that comes through the velum interpositum and through the foramen of Monro comes in, joins the choroid plexus. Hope that's clear to everyone. So these are the three arteries, basically bottom line, anterior choroidal, lateral, and medial posterior choroidal. Anterior is coming from ICA and the posterior is coming from PCA. More specifically, I think P2. And this is a very nice picture of the venous relationship. So as you can see, the structure we just described, the roof of the third, it has the internal cerebral veins, and then you have your thalamostriate veins, which joins the internal cerebral, and the internal cerebral on both sides, they forms the vein of Galen. And then you have on this structure, you can see again from the top. So this is your internal cerebral on both sides coming and forming the vein of Galen. Moving on. So this, I think everyone got this. I think David advised me to put this on in the talk. So what's the surface marking of foramen of Monro? Just above pinna, above and behind pinna, in front of tragus, in front of pinna. So any thoughts? Dan? Hello? Is everyone still there?
Yeah, it's just in front of the tragus, Simon.
Yeah, still here, mate.
Still here. I've talked to Matt now. So we have a couple of issues.
All right. So I think it's in front of the tragus, but it's a bit higher than the tragus itself. So this is a paper that I found online, and it says it's 2 centimeters superior to Terion and just behind the lower third of the coronal suture. So that's kind of there. So I think, yeah, it's in front of tragus, but it's also a bit higher than you would normally imagine. And if you, so that's the surface marking. And if you open, like you have done a craniotomy and you're looking at the brain, so it will be deep to the central portion of the pars opercularis. And if you go deeper, it will be deep to the second short insula gyrus. I didn't put any pictures of that because I felt that it's already too much loaded with information. So now moving on to the surgical consideration. So the most common thing we do about ventricular surgery is the EVD and shunt. So those are the means of CSF diversion. And then often we need to deal with patients presenting with intraventricular tumors like colloid cyst, or sometimes you can have like access the no zone of the brain through the ventricle. So sometimes I think you can approach the craniopharyngiomas and the deeper supracellular structures if you use the surgical corridors through the ventricle. And so this is a diagrammatic picture showing the EVD. So this is the Copper's point. So go from 3 centimeter lateral to the midline, 1 centimeter in front of your coronal sutures, and go perpendicular to the surface of the skull. And you should be in the lateral ventricle of the ipsilateral side. And this is a entry point for a parietal shunt. So it said that if you go halfway between the external acoustic meatus and the inion, and if you go above that, so there should be a flat surface of the parietal bone, which is ideal location for, like if you're putting a chunky reservoir, you should find a flat surface of the bone to put that reservoir or the valve system. And this is a very, I don't know how to describe it, very complex picture. Again, it's very simple in some sense. So these are showing the different approaches to the ventricle. So coming from the front, you can go subfrontal or anterior frontal, and you can access a third ventricle. Like I said, so you can go below here, you can access the craniopharyngiomas. Then again, from the front, you can, as I said before, that you can come either through the brain cortex, so you can come transcortical, or you can use the natural corridor in between the two hemispheres and go transcallosal. And same for behind, so you can come posterior, either transcortical or transcallosal, and you can have occipital access. And this is the temporal approach to the temporal horn, which I said before, that sometimes when you are doing temporal lobectomy, you might encounter the temporal horn. And the things you need to remember is the optic radiation. So I tried to show a video for ETV. Let me, sorry, just going through this one. Can everyone see the YouTube video?
Yeah.
Yeah, all right. So you can, starting from the beginning. So what's happening? So you are inside the ventricle, you can see the choroid plexus, and that's your, I think it's the thalamus striate vein. So possibly you're on the left side. And if you're going inside, so you can see the two mammillary bodies, and that's your infundibular recess. So you are, if you remember that diagram, so that's your A, that's your B behind the mammillary, and behind is the aqueduct. So they will try to do it possibly here. It's a bit different than what we do in Sheffield. So they're not using the figure of 8 balloon, rather they're doing something different. And you can see nicely flowing CSF from the floor, and they're trying to make it bigger. Okay, and if you go inside, you'll have this beautiful view of the floor. That's the basilar, and you have the lots of like membrane of liquids. And I know Mr. Sinat loves to go inside and try to make hole in one of those membranes if possible. So that's it.
Thanks, Amin, mate.
Beautiful, Amin. Thank you very much.
Thanks, Amin.
Thanks very much, Amin. Cheers.
Thanks, Amin.
Yeah, thanks, Amin.
All right.
Thanks, Amin.
Anything, any point anyone want to add? Any questions?
Next week, Hugh's gonna carry on the ventricular theme, and he's gonna go over fourth ventricular anatomy, and he's gonna talk about the telovelar approach and how you can use it with tumours in kids. So it should be a good one. I think it'll be 11 a.m. next week.
Thanks. I mean, sorry I joined late. I was on night. So.
That's all right. Nice to see you, Ifosa.
Yeah. And one question.
Yeah.
You were talking about the EVD slides. I know it's a very common surgery for neurosurgeons, but it's also something you can also make a lot of mistakes. Can I ask Dan, is there any tips you can give to, because I was asking somebody some other day, even professors, they do make mistakes. So I'm just asking Dan, is there any tips or guidance you can give to avoid getting to the wrong place?
Don't stick anything in big red things that pulsate, and generally you'll be okay. No, I don't know. I mean, I think it's all just about training, isn't it? I mean, in Sheffield, we do this from early on because we're lucky to have Rob Sinner. He sees as a training operation. So if you're familiar with the anatomy, then you can avoid complications. I mean, I've only done 30 or 40 of them. There's people. I don't know if is Hugh on it. I mean, Hugh's done lots of these, but I don't know.
In Uganda, yeah.
He went to he was in Cure in Uganda, but I mean it's a very straightforward operation, mate. Know your anatomy, stay in front of the mammillary bodies. Don't poke anything too hard. Have a low threshold to back out. So if you can't get through, usually it's quite straightforward. If you've got chronic hydrocephalus, then the tuber, which is the tuber sensorium, is the piece of neural tissue between the mammillary bodies and the infundibular recess, and it'll be thinned out. And usually you can get something through it, whether you just push the figure of 8 balloon directly through it, or you use the bipolar but off cautery. So don't go buzzing around the tuber sensorium. If it's not a chronic hydrocephalus case, then the floor can be quite thick. So I think just have a threshold to be able to say if you can't do it, then back out. You can always put a shunt, and shunts aren't the work of the devil, So once you've started a case, you don't have to finish it.
Yeah.
You're prepared to back out and walk away. I think even now, I think I would be reluctant to be doing an ETV in the middle of the night. I know people have done ETVs in the middle of the night in Sheffield. I think I'd be reluctant to either A, advise it, or B, do it. I think always think and when it comes to FRCS, think of the safest thing. It's a very common question to come up to kind of guide you down an ETV. So kid comes in with triventricular hydrocephalus obtunded in the middle of the night. What do you do? And you'll have people who have been trained in ETV, and if you say ETV, then you better be very good at talking about it, because they'll catch it out, and always just think of the safest thing possible. So, there's that possible. What's the safest thing to do? Safest thing to do is to put in an EVD. That's my views on it anyway.
Thanks. Thanks, Amin.
Thanks.
Beautiful, Amin.
All right.
Cheers, mate.
Thank you, guys. We'll see you next week.
Okay.
Next week, everyone.
Amin, can I have access to the recorded video, because I came late, so I can have the anatomy?
Yeah, I will. I'll send you the link.
Okay, thanks.
All right. Thank you, everyone.
Okay,
bye-bye.
cheers.
Take care.
Bye.
Can I have the link as well? I'm on call and I joined late as well. Sorry.
I will send it in the group. No worries.
All right, cheers. Bye.